long. Great. My name's Thalia Oster. I'm the chair of the Colorado League of Women Voters Healthcare Task Force, which has all of a sudden taken on more importance than before. With all the cuts coming from DC that will affect our healthcare in our state. So I'm really curious to hear how Senate Bill 45 is coming along. Virginia Gephardt is here. What's been happening up until this moment, and Representative McCormick is a co-sponsor of the bill, and she'll be talking about it as well and what we can do to get it over the finish line. We are a task force, so I always like to ask to get people to brainstorm, what can we do? What will our task be when this meeting is over? And I am also going to say I have weird internet issues, so I probably have to turn my video off. So Beth will manage when I go silent. Okay. So Representative McCormick, would you like to begin and fill us in on where we are? Oh, you're unmuted, but I don't hear anybody.
Yeah, I'm sorry, we can't hear you. You are unmuted.
Yeah, but we cannot hear you.
How about now?
Oh, yes.
Yes.
Awesome.
Okay.
Great.
I had to check a setting. So thank you again for inviting me. I'm not exactly sure where to start, so I don't know how much everyone already knows, or
I imagine this is a pretty educated group here, but go right ahead and just brainstorm and just fly off the cuff.
Then, as you know, this is our third year trying, and the strategy was a little different this year to start the bill in the Senate. And we got it through the Senate smoothly, which was awesome. Then it came over to the House, and we heard it in House Health and Human Services. I can't even remember the date now, but within the last 2 or 3 weeks. And now it is scheduled for Finance Committee on Monday, because the bill, anytime the state takes in money and gives out money, it has to go to finance. Even though this money is coming from outside sources, it still kind of comes into the state kind of purview in a way, and then goes out again. So anyway, it's going to finance on Monday. I did have a discussion with the Democrats on the Finance Committee this morning to see if there were any questions. There were a few questions about if, you know, kind of where the money's coming from, how the fundraising plan is going to be set in motion. I did let them know it'd probably take about 6 months, and that the advocacy groups have partnered with a professional fundraiser that—
oh, that's a relief. Good.
Yeah, that has a plan, and Virginia will probably be able to speak to that a little more detail, and that the Colorado School of Public Health Foundation will be receiving, they'll have a dedicated account to receive those funds, and they won't start the analysis until they have all the projected need to complete the study. If by any reason not enough funds are raised, they are allowed and will have to keep that money, because they don't have a mechanism to give it back, because it's a gift.
Oh, yeah.
But they do have the ability to scale back kind of as needed to be able to do something, which is good, because I know we have some in the bill itself. It has 17 different things that we're asking the School of Public Health to analyze, and they're all permissive in nature. So that will allow them to be able to tailor the analysis if they need to.
Mhm.
But the thought is, and the optimism is that enough funds will be able to be raised to complete the entire study. And so it's the fundraising will take probably about 6 months, certainly after the bill is signed by the governor, which would happen sometime probably in May, because we probably won't get it done in time for him to sign it before we're out of session. And then hopefully they'll be able to start the study before the end of the year. And then they have a full year to complete it.
Yeah, December of
Yeah,
next year.
so that's where we are. I am honestly not 100% sure if after finance they're going to make us go to appropriations or not.
Oh, man.
They, I don't know. It's kind of weird. The routing in the House is different than the Senate. And if that's the case, again, it's just these stepping stones that we're doing. Even though we're not asking for any state money, we kind of have to follow the rules, whatever they are.
Yeah.
So
What's the total dollar amount that
well, the total dollar amount that's on the fiscal note is actually not even correct, which is kind of weird. I think it's around five. Virginia might know too. I don't have it in front of me.
Okay.
500,000-ish over the period of time. So it's so much, and then it's so much.
Sure.
The first fiscal year and then the second fiscal year.
Mhm.
So, and what folks can do to help, you did mention that in your opening, is probably don't need too much help contacting the folks on the finance committee, but it's more the representatives in the House, no matter the party. And thank goodness for Senator Cleve Simpson. So I think he's the only Republican we have, but he understands the need for this data and this study to be done in order to answer these questions for the people of Colorado. And you all folks in the know, and we've heard from Dr. Tung at Colorado School of Public Health, that this is a very important step with critical information that we have to have. But it's very likely that with this information, if all looks good and positive on the road forward, that we might actually need an implementation analysis. Like, how do we actually implement this? Because those are also questions and aren't not going to be answered in this study that the voters of Colorado may need to have answers to that before they have a fully educated view on potentially voting on a ballot initiative again. But we've been waiting so long to get this step done that I'm very hopeful that we're gonna finally do it. So I'll stop there.
Okay, great. Virginia, you want to jump in now? And then I know we have Marcia and Brianna, anyone else who actually testified at the last hearing, so we want to hear from you as well. But Virginia, why don't you chime in here? You're on mute.
Sorry, can you hear me now?
Yeah.
Okay, thank you, Thalia, and thank you, Representative McCormick. I would just chime in with a little bit more of an explanation of what the Colorado School of Public Health has done. Some of you on this call probably know that they did an analysis in subsequent to HB 1911-76, HealthCare Cost Savings Act. And that analysis was an analysis on a system-wide basis, costs and so forth at the systems level, so that they analyzed and learned that a publicly financed, privately delivered health insurance system could actually save up to billions of dollars per year in Colorado while covering everybody. And
Mhm.
so, if that's really true, wouldn't it be great to learn a little bit more about that? And
Mhm.
what we need to learn is, if we're to ever bring it forth an initiative for the people to vote on, is we need to learn more on an individual basis, on a not on a system-wide basis, but on an
Mhm.
individual basis, so people can understand, well, how would this affect me?
Mhm.
What could be covered?
Mhm.
Does this include mental health services?
Mhm.
Can it include long-term support services, which
Mhm.
is really important because, our long-term care system that we have often impoverishes people, and people worry about that their entire lives, and families are affected by that. And so many other things that they want to, that people need to know before they can be informed and say, well, yes, this is something that would be good for me and for my family, as well as the whole state. And if it's successful, it could be a model for the whole country. And
Mhm.
so that's why we need this further analysis. And as Representative McCormick said, it's not going to be the be all end all, but we do need this particular step as the next step. As Dr. Tong has said, that this analysis won't tell us how to implement such a system if it turns out that it's
Mhm.
something that's feasible in Colorado, but it would tell us what could be included. Could all of these things that we want be included? Or
Mhm.
is, zero co-pays or no
Mhm.
deductibles? Is that a bridge too far? Do we have to have
Mhm.
that? Can we really lower drug costs and so forth?
Mhm.
And all of these things that are so important before people can make an informed decision.
Mhm.
This and what they did with the first study that they did and report to the legislature in 2021 was they built a powerful microsimulation model, and they want to build on, use that again, only go deeper into these details. And so that's what we're asking them to do, and they're eager to do it, because they're the Colorado School of Public Health, and
Right.
they want to do what they can to serve the community. And
Mhm.
if this is if this is feasible in Colorado, what it could be transformational in terms
Mhm.
of health for individuals, but also in terms of public health.
Mhm. Mhm.
So I guess I'll stop talking there. And if people want to ask me further questions, I'd be happy to
Okay.
answer.
Great. And also, thank you, Virginia. I had a question and it just went right out of my brain. It'll come back to me. But
Okay.
Marcia, Brianna, you guys want to chime in? I heard your testimony last week, I think, and your individual stories I thought were really powerful. It seems like when you're testifying or when you're dealing with a bill, a lot of the conversation is academic. It's way up here, and so your stories, and Virginia shared a story from a friend as well, really, I thought, brings it home, and it makes it harder, I would think, for senators and representatives to vote no, on this educational thing that enough people in our state and enough senators and representatives in our legislature are passionate about. So, Marcia, you want to jump in real quick? And nice to see you, by the way. Did you?
know.
Yeah. Is it snowy up in Crested Butte? Did you get some more snow?
Not well, we did a few
No.
days ago, but it's,
Okay.
right before the spring weather came in, and boy, it is just melting. It's
It's a
shocking
mess.
every hour. It's like,
Yeah. Right.
gosh, there's, my planter box is showing up, which is exciting. So
Yeah.
yeah, well, thank you. Good to see you, Thalia. Thank you so
Yeah.
much, all of you, for joining us tonight. And Representative McCormick, thank you so much for being a prime sponsor. Like, it just
Mhm.
really appreciate that. And I really feel honored and appreciate the opportunity that I was able to share our story.
Mhm.
Of course, I wish I had much more than 2 or 3 minutes, but
Yeah, right.
okay, I'll take what I
You
can
never
get.
do.
That's right. But really appreciate the opportunity to testify to both the Senate Health and Human Services Committee as well as the House. So thank you for allowing me to speak and share our story here in rural Gunnison County. So I guess a couple things that I just also wanted to maybe ask because I am really eager to start talking with folks about this. I feel like it's a little bit too early. Folks aren't really at least my circle of folks, they don't have time to be writing letters. And so I have written letters to my representatives asking them to support it. Senator Catlin did not, and I have a draft letter I've not sent yet that I'm calling out that he didn't vote for it, but it's I guess what it is. But I also did send a letter to Representative Sukla asking for him to support it as well. But I want to be ready with answers to share with folks and initiate conversations to let people know about this. And I just think some of the questions that are going to come up is, yes, you know, how much does it cost and who's paying for it? So we have some of we have some of those answers. Being able to maybe spout off a round number of maybe what it would cost is helpful. But I think something more important that is more home hitting for at least my community is what will it ultimately cost me in the end? There's a lot of fear about change, even though there's a lot of miscommunication, misunderstanding about even our just current system that we see every single day as folks walk into the office and they don't understand what their insurance is. They don't understand why they have to give us their new card every year, you know, just like basic frontline
Right.
stuff. And so I'd like to be able to answer some of those questions as far as what they could expect or how much it would cost, because of course they're like, I'm, you know, paying $20,000 or more a year for the privilege basically of having a high deductible of 16 grand a year for my family. And, you know, they just like, I think
It's
I
crazy.
want to be able to be prepared to say, yes, but you don't, it's going to replace some of those costs. It's not, you know, on top.
Right.
And so what, you know, what could they expect? It would be sliding scale or whatnot based on folks' income. Well, what about people who don't work? Maybe they're disabled. So how does that look? So I just want to have some of those kinds of answers. And I don't know what those are right now. And I'm happy to tell people I don't know, and we'll, you know, find out what those answers are. And I feel like that's also part of what the study will do, right? Is answer some of those questions, and perhaps this implementation analysis you were just mentioning further answers some of those questions for how that actually will unfold, which is why it's important to support this particular legislation and study. So that's a whole nother thing that I'd like to ultimately get into, but I'll stop there.
Yeah, no, that's good.
Dr. Anthony, if you want to chime in.
Yeah, and Marsha, I'm looking forward to meeting you in the future. Hi, just to introduce myself, I'm a family medicine doctor in Fort Collins.
Oh, great.
I graduated residency in 2020 to embark on
Wow.
my career. And I joined a really great local practice, physician-owned, multiple clinics. I would say like about 40 different providers. Who, once you're there for 2 years, you become a shareholder. At just around that period of time, things were really hard in COVID for like, honestly, almost any private clinic, no matter if it was primary care hit hard, but all across the board, getting gobbled up by private equity or corporations. And that's what happened to us. And within 2 years, it got so bad that my mental health got really bad, my physical health got bad, and I just couldn't do it anymore. It's like ethically, I couldn't do it. It was just getting really gross. Yeah.
I can assume what caused those hardships for you, but can you spell them out a little bit? What did the private equity firm demand of providers and that kind of thing?
Oh, absolutely. And so basically what happens is like appointment times decrease. So now it has to be standardized that everyone has to have 20-minute appointments, no matter what it's for, even for new patients. So therefore, you're seeing expected to see like 20 plus patients a day. Then your admin time is lunch. And so now you have no admin time to do lab results or call patients or anything. And then they're short staffing. And then, the front desk is struggling. And then they offshored our call center.
Oh, gosh.
Yeah,
Oh,
so they offshored the call center.
oh,
And then there was also like, even based on how our payment system was, upcoding. So if upcoding is basically, especially for Medicare Advantage, where you make a patient look sicker than they are so that you get paid more, basically.
Yep.
So like our pay was based on that. And a lot of doctors don't know. Like, we don't know this. Most doctors you would talk to wouldn't know the difference between Medicare and Medicare Advantage, like, to be honest.
kidding.
Um, once you do know, you have a lot of feelings. But and so that was happening, and then it just got, like our social workers started getting fired, and they were only able to see Medicare patients. So they would give us a handout on, if you have a pregnant person who's suicidal, like, give them this handout so they can go somewhere else, because
Oh,
we're
gosh.
using our resources for Medicare Advantage patients.
Oh,
And so things just really got terrible there. Not supportive to anyone who worked there. And it was really bad. I mean, it's gotten to the point, like, I left a year ago. I opened up my own small specialty clinic where I'm not doing insurance. So I really kind of took a step back from primary care, unfortunately. But now that other people's contracts are up, 8 of over 50 providers are not
they're
staying.
not real.
Like, that's just that big of a loss of a community in like 3 years.
Wow.
So that's my story in terms of what they do. But I think just the big thing is, like, they're the ones who are limiting appointment times, and doctors don't have control of it. They're the ones who are pressuring, oh, like, you only have one problem per appointment to talk about.
That's
They're
not
the
enough.
ones who are, and then, like, when you're an employee, and I wrote down some statistics.
Good, okay.
An employee, which is, oh, where did I write that? Sorry, give me one second.
That's all right.
Doctors now are more likely to be employed than own anything. So the majority of doctors are, ER doctors specifically, are almost completely employed. And so and then, for instance, United HealthCare, they have about 90,000 employed doctors, which is 10% of all of the doctors in the United States. So, like, the clinics that United Health owns is employing 10% of our workforce.
Interesting. I
Yeah.
didn't even know that United Healthcare.
Oh, actually, let me share this,
Okay, yeah, go for it.
because I have a couple other slides, but let me show you
Oh,
a
yeah.
couple that just, like, blow my mind.
Okay. Just
I-
what we all need, right? To
Yeah.
have our minds fun
You get
again.
stressed out about
Every
something.
day, every half hour of every day.
Oh, shoot. And now it's not going to come up.
Well, and while you're looking for that, Dr. Anthony, I would just mention, there's a number of reasons why physicians are leaving independent practice, whether they're primary care specialty, and seeking employed physicians. And I don't know how much maybe we need to educate our representatives and senators on this, but it has taken a significant shift, and there is just and I mentioned this, I think, in my testimony a week or two ago, over the last 15 years of the practices I've managed, the amount of administrative burden, it has just gone through the roof, and it's not lessening, it's worsening. The reimbursement to be able to try to hire additional staff isn't increasing. But the cost of living, my God, it is just like through the roof, you know, in our state, in our area, but I know it's in other places too. And it just makes it really difficult, all the challenges with IT requirements and EHR requirements. You know, I think Dr. Anthony did a good job of spelling out some of the administrative garbage she's being, you know, asked to do as a physician, and it's not taking care of the patient. That's what's so criminal about this, is
Exactly.
it's taking away from time that the patient wants with their doctor, and it's taking away time that the doctor wants with their patient. And
Mhm.
it's this whole other, you know, army that is just interfering with that being done. And trying to then stay independent and, you know, making sure the lights stay on and keeping good staff around and all of those things. It's too much to be doctoring and doing all of those things. And so
Right.
it's really ground down providers that they can't do that anymore. And so they're looking for answers. Nobody really wants to do this. It's just to be able to stay in our communities. And, you know, in my practice of our ultimately six providers, two left our community with their life circumstances, which had a big impact on our practice. And then we were struggling with recruiting and replacing them, for example. You know, a couple are at the end of their career. One ultimately retired at the end of last year. So that's another provider out of our community. We couldn't get anyone to buy into our practice. They just don't want to do that. And they have debt as they come out
Oh,
of
big debt.
residency and medical school. And so
Right.
like,
Yeah,
yeah,
I took
sign me
credit
up to pay
card.
another $250,000 to join a
Sure.
practice. Like,
Right.
it's not there. We
Mhm.
can't do that anymore. So we
Well,
have
and
to do
the
something
equation
different. The
doesn't,
system
yeah.
is just, it's not sustainable as it is right now. We have to do something different.
And I will say, if you ask any doctor or PA or NP, notes haunting, like literally hours and hours and hours of home time trying to finish these notes, mostly for like billing reasons or like to make sure you're not, you know, it's so ridiculous how much that takes. I can't figure out how to share my screen, but I just put in the chat, there is this infographic, and I confirmed that all of these are real and databased. But
It's a good, yeah.
this shows that all of it is vertically integrated, right? And so like CVS owns Aetna, which owns a pharmacy benefit manager, which I think some people know about, which then owns the pharmacies, which then owns clinic. And so like like they don't care about doctors. They're getting money all the way down the road. So they could care less about your opinion about anything unless they're making more money. And they make money the whole way. Like the whole way.
So
Well, it's
you
too
guys see
bad
the
that
graphic?
the two of you, if your representatives would be willing to have to listen to you long enough, just to hear your stories, that should convince them to at least be interested in finding out if this is a solution. I know that, and I thank you both for your testimony. And I know you only got 2 minutes, but it was impactful. But I think that for those, you were asking, how do you get your story out, or how do you talk to people that are afraid of change and think this is going to put them in a worse situation? Many people, especially some, you know, on the the right side of the political spectrum, are super interested in efficiency. They're super interested in being fiscally responsible and wanting better health outcomes. And as a private business owner myself back in the day, I was sick and tired of being the employer between my employees and their health care. And you know, you have the insurance company between your employees and their health care. Then you have your employer between the employees and their doctor. Can we get those two out? And
Right.
improve efficiency, improve health outcomes, improve provider pay, and improve physician and other providers' job satisfaction, and cover everybody. Like, I know it sounds like a dream world, but what's wrong with finding out if it's really possible
Yeah.
for us to save $5
Yeah.
to $10 billion over the next 10 years? Because all of those inputs, when people think about their premiums that they pay or that their employer is paying for them, you know, if they're paying half or all of it, all of that is going to be considered in these microsimulation models. All the inputs are going to be considered: your co-pays, your deductibles, your premiums, ERISA plans, Medicaid, it's all going to be considered. If we take the whole thing into a bucket and we figure out, can we cover everyone, and all the things that are listed in the bill, cover even those that are just showing up to emergency room and don't have any coverage, but we're paying for that too.
Right.
And be able to take the people out of the middle eventually, so that, you know, this chart that you have just shows that we all know that insurers, PBMs, everybody, their goal, good for them. I mean, their purpose is to make money. Their purpose is not healthcare and
Right.
health outcomes. And so I just tell people, why are you afraid of information? This could actually be much better for you
Mhm.
if you run a small business. And all in all, we shouldn't be afraid of data. And those people that really just kind of shut down on me last year and said, there's no way we can afford this, I just turned that around on them and said, wouldn't you like to know for sure? So that the people of
Absolutely.
Colorado will perhaps stop asking, because then we can turn around and say, here's the report. Guess what? We can't afford it. 6 million
Mhm.
people isn't enough people to stand this up. So I just make them face that fear and go, can we just find out?
Right.
Yeah.
And especially if it's not going to take money out of the state budget. I don't see why there should be a problem, except that those on the right side, you know, they don't like change, but also, like you said, Representative, they like efficiency, but they also like the free economy. And I think that's the biggest obstacle, right?
I would
You know,
have them explain how the free market works in healthcare. Have them
It
try to
doesn't.
explain that.
And
We
that
know
it
that.
doesn't.
integration,
We know
that's
that. Have them
It's
try to explain
insane.
it.
yeah.
Have them try to explain it, because
Right.
it doesn't exist in
No,
healthcare.
it's terrible. I mean, I'm not a healthcare provider. True confession here, I'm a lawyer. Husband's a retired foot and ankle surgeon, so I have a lot of similar experiences that Marcia does. And it just, you know, he was in private practice for most of his career, and then it became unaffordable because money is in between the doctor and the patient, which should never be anyway. You know, and now that I'm a relatively new Medicare patient, it's fantastic because everybody knows it's all set. You don't have to worry about money, and it doesn't come between the patient and their health or their relationship with their provider. So in my mind, I think I have always thought this was something that needed to be done. You know, and I really hope we can make it happen. Virginia, go ahead.
Thanks, Thalia. I noticed as you were talking, you like I have reached the promised land of Medicare. So,
Yeah.
and we love it. So wouldn't it be great if everybody had it?
And I'm
Right.
jealous.
I wanted to throw in something that I'm kind of a public TV nerd, and I watch
Mm.
the public affairs shows on Friday evening all the time. And the Firing Line show that Margaret Hoover show has on PBS on Friday night. She had some guests talking about what Doge is getting wrong and advice for Elon Musk. And one of her guests was a conservative speaker. His name is Philip K. Howard. He runs a nonprofit called Common Good, which advocates to simplify government, which is a goal that we would all support, but especially our friends on the right do. And this was the topic of the evening, what Doge is getting wrong and advice for Elon Musk. And here's what he said. There's one area with hundreds of billions of dollars in savings that requires major overhaul, which is in the healthcare administration area. If Musk and Trump really wanted to save big amounts of money, they would simplify the healthcare reimbursement and regulatory system, because 30% of the healthcare dollar goes to administration, which is over $1 million for every American doctor in red tape.
Wow.
That system is crazy and it needs to be completely, basically replaced, end quote. And I would just add, of course, that there are many other people who share this crushing administrative burden to make up that $1 million of red tape per doctor. It's not just the doctors, it's also the nurses, pharmacists, licensed clinical social workers, psychologists, physical therapists, hospital administrator, clinic administrators, small business owners, and really just about anybody who needs to use their health insurance. We all have to deal with this. And it's my dream that this analysis will point this out among many other things.
Right.
That, I don't know what the savings would be in Colorado out of that over $1 trillion that's spent on administration in this country, but it's significant.
Absolutely.
I added a couple other infographics, mostly just to show like this, it's so complicated, it's so wasteful. It no matter what is, it just isn't gonna, it's not gonna work. Like this is not sustainable. I think another statistics was that 40% of physicians are highly thinking of or definitely thinking of leaving within the next 5 years.
Wow.
Does anybody know if admissions to medical school, nursing school, etc., are holding steady, going down? Does anybody know?
I know primary care is going down, and I know residencies in certain states like anti-abortion states like OBGYN aren't getting filled.
Okay, there's another one of your graphics there. Can everybody see that? Good. Virginia?
Those graphics are marvelous.
They are.
And what I was going to say concerning healthcare professionals is that if there truly could be a savings of $1 billion per year in Colorado on healthcare spending, $1 billion would pay a lot of tuition for a lot of healthcare professionals. And I know that Colorado has already passed some laws to provide support for various professions like nurses and so forth. And it just needs to be expanded so that people who grow up in a community, say a rural community, and want to be a doctor, but just can't even dream of it because it costs too much, could actually go to medical school and come back and serve their community. I grew up in a small town in South Dakota, and they learned 50 years ago that if you want to keep doctors in rural communities, you got to grow your own. And so they started paying tuition for college students if they would come back and practice in the community. So
In South Dakota did this.
yeah.
Wow, that's impressive.
Well,
Yeah.
it just my community. It wasn't a statewide program.
Okay.
But they figured it out long ago. I mean, it's been a huge problem in rural America for years, as we all know.
Absolutely. Marshall, you've got your hand up?
Yeah, I I have been studying this system for, I don't know, 30 years. I started at Georgetown, but I wish you great luck. And something needs to happen, and I don't know what it is, but I don't know how you'll get there without blowing it up.
Changing the system altogether, right? Anybody who has not shared their thoughts, like to jump in? James or Helen or Tony or Suzanne?
This is James. I have a question. W- One of the hindrances, to make this more difficult would be Tabor. Is there any, talk about trying to do away with Tabor anymore, or is that something that we'll never get rid of? And the cost of that study, I think Representative McCormick said around 500,000. Is that a fairly good number? And thank you all.
Yeah, you're welcome.
Oh, may I? I'm sorry.
Oops, that's okay. I was just going to answer for him real quick.
Me too.
So we're always looking at getting rid of Tabor and trying again. This study will also take that into account. Like that's part of what they'll also
That's good.
consider. And what was your other question? I don't know why I just blanked out. Oh, the cost of 500. Well, it was going to be like as high as 750,000, I think, depending on what the cost of the looking at long-term services. But I think the current fiscal note still is closer to 400. So it is well worth it to have these gifts, grants, and donations come in to pay for this. And the School of Public Health is very excited about completing this analysis. They really want to do it. So they're all on board and they've got the people ready to do it.
Fantastic. Tony, you want to jump in?
Yeah, there are several things there. First of all, I don't know how successful gifts, grants, and donations has been in the past. There was a period of time when we attached that to a whole bunch of legislation. And I don't know if we've done any research on whether or not that was successful. And then going to the issue of Tabor, there's a whole bunch of stuff that's not going to be possible unless we either modify or do away with Tabor. And even if you get all the information that you need from this study, you may not be able to implement it if we keep having this artificial cap on our funding, and that we, at this point, we're not letting our legislators do their job of deciding how we need to pay and what we need to pay for. So it's really important. And there are some things going on in the state legislature about Tabor. So if you catch any of that, encourage your legislators.
Great. Virginia?
I'll let Virginia talk about the fundraising in this particular situation.
Okay, thanks, Karen. I will say that one of the essential elements that is included in the bill that we are asking the Colorado School of Public Health to analyze is it possible to establish an enterprise to receive the funding? And it would be basically that all the premiums and so forth that we pay into an insurance company now would instead go into an enterprise, and then the enterprise would then pay the healthcare providers, and it would just be simplified because it'd be one system to fund and to understand and to figure out the payment system. So that right there would be, like I said, would be my dream. And I will say that because we really urged that the Colorado School of Public Health include a really rigorous analysis of long-term supports and services this year. The fiscal note has increased to like $750,000 for the entire study. Whereas in the last bill, in the previous year, Representative McCormick worked very hard to split up the fiscal note, which was smaller to begin with, into 2 years, because that's the way we had to kind of work with the available funding, discretionary funding last year. And so it's my understanding from the fiscal note drafter that because the language of the bill didn't actually change, that she wanted to stick with this lower number, because that's just what they do, is that they stick with a lower amount of a fiscal note when they can. And she didn't know about our conversations with the Colorado School of Public Health, telling them that, we really do want this rigorous analysis of long-term supports and services, which is, nursing home care and home health care and care for people in the disability community, because number one, it's the right thing to do, is to include them in a comprehensive plan for everybody. And number two, that's lots of people who would be interested in that very fact. I mean, it's not just because it's the right thing to do, but it's like, well, I'm on disability now and I have really good care and coverage, and you're not going to include me in this analysis. Well, I would be afraid to change to something else, even though you tell me it might be better for me. We just need to have that good data. And the reason that it increased the cost of the analysis so much is that much of the long-term care, as we all know, is uncompensated. It's people in homes, families, neighbors, friends, spouses, family members doing the care, and they're not compensated for it. So to truly cover those expenses and comprehensively, they're going to have to, dig deeper, and it'll take more to build a microsimulation model for that particular segment of the analysis. And, they told us that it would cost that much more. And we just said, well, we really need to include that. So, and we'll commit to fundraise for that. So that's our plan.
Awesome. Representative McCormick, do you have any experience with the Colorado legislature whenever an enterprise option is introduced as a way to circumvent Tabor?
Well, actually, Tabor allows, back when it was voted on, Tabor allows the creation of enterprises. So if anybody says you all are just, circumventing Tabor, Tabor allows the creation of enterprises, and then enterprises are separate from the Tabor cap. So we're sticking with the rules.
Okay, good. That's good.
Yes, and that's exactly right. It would be a nonprofit enterprise, so that 30% that's being spent in administrative overhead would be more like what Medicare does, which is more like 3%. And hence the savings and the ability to cover more people for more things. So if legislators push back and say, you're cheating, you're circumventing Tabor, just let them know that, and understand that this is really a way for us to save money for the people of Colorado.
That's terrific. Anybody have any other comments or questions?
So I had a question.
Go ahead, Suzanne.
Yeah, I had a question. And I'm part of the Larimer County League of Women Voters health team.
Good.
So I'm
Nice to
particularly
meet you.
interested in this topic. And I was just wondering, Representative McCormick, you were saying that you would have 1 year to complete the analysis and then might have to ask for an implementation study after that. And that would take a ballot initiative, is that correct?
Well, no, the good question. This analysis is going to answer a lot of questions that are the foundation of whether it's feasible to move forward. What this analysis does not answer is how the heck do we do it? And just in conversations with Dr. Tung and Glenn Mays and others at the School of Public Health, they can visualize a way that it might be a system that has to be implemented in stages over a long period, like 10 years, because basically we're shutting down health insurance.
Yeah.
And that's the pushback that you get from all of those that are in the health insurance world. But many of those jobs could become other jobs, certainly. And so you can't just turn it off. You can't just blow it up. You can't just turn it off with a switch. We are so entangled in this over the last however many 70 years that it would take some figuring out how do we start the process, and is it in steps with certain insurance markets first or what? So and probably the School of Public Health or someone would have to do that analysis as well. What would be the best or 3 different ways to now implement it according to what we've got here? And then if we had all of that information, the what and the how, then it would take the advocacy organizations, the people of Colorado, to figure out how to bring it to the ballot as a ballot initiative, gather signatures, that sort of thing, or have it go through the legislature as a referred ballot initiative. But yeah, we're still many steps down the road here.
Marsha Marshall asked in the chat, she says, but what happens to Kaiser Permanente?
Well, all
Marsha,
of the groups that are the payers would, even the ERISA plans, are
But Kaiser is nonprofit.
right, but
I
they're
mean,
still
and
part of the inputs. They're still part of the input system. And so if we really want a single paying system,
well, then
you're not left out of the analysis anyway.
Okay.
I mean, I will say, just because it's a nonprofit doesn't mean its goal is not profit. Like, for instance, there was just a story about how a patient lost her baby prematurely, and they were charged over $2,000 for the baby's stay at the hospital.
Yeah.
And
Well,
UT
and
Health
all
has
the
not
hospitals are
impacted,
different.
Yeah.
All the hospitals are independent in Colorado, and there is no certificate of need, and there's very little control over the growth of hospitals, and that's where the money is.
Virginia?
I would just say another way to think of the Kaiser question is that Kaiser is both a nonprofit insurer, but it's also a healthcare provider. So they could stay a healthcare provider. It's just that their insurance side would be different. And theoretically, you pay premiums into Kaiser now, and instead those premiums would go into the enterprise. If it could be a truly single payer, or as Dr. Tung likes to call it, a single channel. And when he first started talking about single channel, I thought, what are you talking about? I've never heard that before. And even Representative Brown, when Dr. Tung said that the first time, Representative Brown said, I've been in the insurance industry, looking at it. I mean, he's not been in the industry, but he's an expert on health insurance, let's put it that way. He said, I've never heard of that term, single channel. And what Dr. Tung is talking about is that you'll still have a lot of funding streams that are the same, like coming from the federal government and coming from the state government, paying for the healthcare, but it'll go into this one enterprise so that it's simpler for us as patients to deal with, and it's simpler for healthcare providers to deal with. And, hopefully it would end up saving money. And so there's just a lot of ways to think about this. And I'd like to throw out another simple thing for both the healthcare providers like doctors and for patients, is that hopefully the providers would be paid appropriately so that they could survive and thrive and make a good living and have a decent, life-work balance. And they would all want to be in the network. So everybody would be in network, and there would not be this constant churning of having to change doctors just because your insurance company tells you have to change your doctors. So that alone would improve healthcare, right?
For
there.
sure.
So
It would.
there are just so many ways that and this is basically just simplification of the way we pay for healthcare. Just simply, simpler public financing, while all of the, healthcare providers remain privately owned as they are now in private business. And, they're not employees of the state or anything. They're still self-employed or employed by a business or whatever. So it's just all of this talk that we're having is just, we're trying to simplify the way that we pay for healthcare so that it's the same for everybody. So everybody gets treated the same. There's no incentive to treat somebody over here because you might make more money off of them, or not treat somebody over here because they can't pay. I mean, that's the way the system treats us now, and it's not right.
Exactly.
Yeah, I'm gonna have to sign off. I'm sorry.
Oh, no, it's time. Thank you so
Okay.
much,
I appreciate
Representative.
you all and all that you
Oh,
do.
Thank you.
Thanks. Likewise, thank you. And just so everybody else here knows, I really appreciate the input today. This was really, really informative, especially with all this churning going on from the federal government and the announcements today that they're gonna pull, trillions of dollars from healthcare. I think we all need to be, what's the word I want? Nimble, and learn as much as we can, which brings me to my meeting for next month. Our healthcare task force meeting is April 24th, 6:30 again via Zoom. And it's on the intersection of Tabor, the state budget, and potential federal cuts. So it would be a good continuation of this conversation. So thank you, everyone. And you'll get, a link to the recording.
Thank you.
Thank you so
Thanks,
much,
everybody.
Sylvia.
Okay.
Bye.
Everyone.
Have a good evening.
You too.
Thank you.